Okay, hello everyone. I think we'll get started. Thank you for attending the last webinar of 2018 for our Teach Educational round. With us here today we have Marilyn Campbell and Dr. Aviva Rostas, who will be presenting on the nicotine dependence in older adults. But before I hand it off to our presenters, I'm just going to go over a few housekeeping slides as per usual. So first of all, if you're interested in obtaining a letter of completion for this Teach Educational round, please make sure that you have registered for the webinar and completed the pre-learning assessment. You have signed in to view this webinar session using your first and last name so I can track your attendance. And finally, you complete the post-learning assessment after today's webinar, and I will send you a link that you will have 1 week to complete this afternoon. You can follow us at Twitter at PSQuitSmoking and use the hashtag TeachWebinar to post or read questions. Here is a biography of our first faculty presenter, Marilyn Campbell, who is a clinical geriatric addictions consultant and addictions case manager, COPA, with Reconnect Community Health Services. She is also the provincial lead for BSO Brain Exchange Older Adult Substance Use Collaborative. Marilyn is the recipient of several awards and has 30 years of clinical experience, making her a pioneer in the field of geriatric addiction. Here is a biography of our second presenter, Dr. Aviva Rostas, who completed her undergraduate training at the University of Western Ontario and then attended medical school at McMaster University. She is currently on staff at the Center for Addiction and Mental Health and works in the Geriatric Psychiatry Inpatient Unit in Transitional Housing for Seniors and consulting to long-term care homes. Dr. Rostas is also a lecturer at the University of Toronto. Here are a list of both presenters' disclosures, which have been mitigated in the following slides. Remember, the content of Teach Educational rounds are centered on evidence-based guidelines from the following resources. These materials, as well as the verbal presentation and any discussions, set out only general principles, and they do not replace the need for clinical assessments or treatment plans by healthcare professionals. And before I hand it off to our presenters, I would just like to do a few polling questions to gauge who has joined us here today. So in a minute, using your computer, could you please indicate which of the following organizations you work for? And if your organization isn't here, you can always type it in the chat box. So it looks like we have some addiction agencies. I see some responses from hospitals, family health teams, public health unit. Great. And in a second, using your computer, can you also indicate what your current discipline is? And you may need to scroll down to see all the options. So some registered nurses, health promoters, some tobacco quit specialists. Awesome. Okay, and the last poll, could you please indicate what region your organization serves? The Northeast area. Oh, Toronto Public Health, Home Oxygen Company, Outreach Mental Health Teams in the chat box. Great, thank you everyone. So with that, I will leave it to our presenters to get started. Thank you and enjoy.
All right. Thank you, Stephanie, for the lovely introduction, and it's very exciting to see all sorts of disciplines and people from lots of different places attending our webinar today. So in terms of our learning objectives, by the end of the session, we're hoping that we'll discuss what's known about nicotine dependence in older age, identify some evidence-based treatments for nicotine dependence and considerations for use in the older adult population, and develop an approach to smoking cessation in older adults and for those transitioning to long-term care.
So we'll just open up with a case. How do we advance the slides, Stephanie?
You could just press the arrow button right at the bottom. Do Do you see where it says next page? Rape is,
Oh,
yes.
okay. Got it. Okay.
Thank you.
So we'll just start with a case, and I want you to reflect on this as we're talking, and you know, come up with some ideas on how you might handle this situation. So this is a 75-year-old male where he has dementia. He's living in long-term care. He's a long-term smoker, smokes a pack and a half a day, and there's lots of safety concerns, and this is common in long-term care. He's smoking in the long-term care washrooms. He's demanding his cigarettes. He becomes aggressive. You know, he's refusing to return the cigarettes and the lighter to staff, and that's kind of the typical thing that happens when in long-term care is that, you know, residents that are safe to smoke, usually they get their cigarettes and they hand back the lighter to folks at the end of the, you know, their smoking time. But this time he's refusing to return the cigarettes and the lighter. And sometimes he returns the cigarettes but not the lighter, and that creates a whole other host of problems for people in the long-term care, because other patients with dementia, then he's lighting cigarettes for them. So so it's a real safety concern. So what would you do? So I'd like to, as we've done our slide, and have a discussion later on what some of this will.
So, you know, that smoking in older age is common. Although in the 65 and older group, that's the general population, it's quite high. So if you look at the bars all the way to the right, it's just about 10% of older adults age 65 plus are current smokers. So I would see that there's some difficulty hearing. Hopefully it's a bit better now. We've just adjusted our phone. In terms of rates specifically in long-term care, there's not much data out there, but I have found in one study that rates are cited as being 5% prevalence of smoking in long-term care.
Is it better if can you hear me better now? Okay, so we'll speak closer to the phone.
Yeah. We'll lift up the phone so we're not talking into the table. So in terms of negative outcomes, it's not new information, and most of us know that smoking is associated with many negative health outcomes. This is an interesting figure from the World Health Organization where they've listed the 8 leading causes of death worldwide. So things like heart disease, cancer, cerebrovascular disease, other things like HIV/AIDS, diarrheal illnesses, tuberculosis. And what they've done is for each of these types of diseases, they've tried to guess how much of the burden of each disease is attributable to smoking. So the hatched portion of each bar is the part attributable to smoking. What they found is that for 6 worldwide. And then when you think about older people and when you think about people living in long-term care, of course there's all the terrible health outcomes associated with smoking. But the other piece that's important to consider is the risk of fire. And we know that in those age 65 plus, fire fatality rates are actually twice as high as in younger people. And in long-term care homes, smoking-related fires are the main cause of fires. Why is this? So some of it may be due to cognitive impairment. So as people get older, there can be development of dementia, cognition can decline, people can have more difficulty in figuring out kind of how to use the cigarette or forgetting to put out the cigarette. But there are other things as well. People can get older and develop tremors. People can have generally just more trouble with movement and coordination. There can be visual impairment. So all of these things come together and can increase risk of burns and fires. And unfortunately, it's a very real risk. It's not something we just see in the medical literature, but this is something we see in our news fairly regularly, is smoking and fires in these seniors' housing.
So we know that nicotine has a very, very high addictive potential. It has a short half-life. and very rapid route of delivery. So when you inhale a cigarette, the cigarette smoke, it reaches the brain very, very quickly. And overall, it does people tend to identify that as something that's very, they become very addicted quickly. And it's considered one of the most addictive substances. The nicotine is absorbed through the lungs, and the nicotine levels in the blood reach a peak literally within seconds, and then they decline rapidly. So this is repeated and reinforced with every inhalation, and that quick delivery of nicotine to the brain results in faster and more intense response, and that leads to the addiction. So this picture shows the areas of the brain which involve nicotine dependence. So, that's the one thing is that people will often say to me when they have addictions, it was a lot harder to, it's a lot easier to quit drinking than it is to quit smoking. So in terms of withdrawal, okay, I'll let you take care of that. So as soon as the nicotine levels are lower in the body, then there's an immediate onset. So this means that people will immediately experience cravings to smoke. They'll be frustrated, they'll be angry, might have some difficulty concentrating, restlessness, and that can occur within a few hours of cessation, and it peaks in 1 to 4 days, and it can last 6 months or longer. So you want to take into consideration an assessment of behavioral and psychological symptoms of self-dementia. So when you think about it, if you have an older adult with dementia is being admitted to long-term care, and this is their first day in the residence, and they've come in and they don't have nicotine on board, they're not allowed to smoke, or they don't have nicotine replacement therapy, you're probably going to see some behaviors. If a person is stopped even later on in the course of their treatment, they may still experience some other symptoms such as nausea, diarrhea, or constipation, which is always a problem in older adults, dizziness, fatigue, sleep disturbances, and headaches. And those are typically milder than those immediate onset symptoms, but they can last 6 months or longer. And it can, if they smell it, it can trigger the cravings as well. So the next one is the e-cigarette. So the cigarette. It's not nicotine, and so we always worry about people saying, well, you're replacing one substance with another. The cigarette has all of these chemicals in it. There's over 2,000 chemicals in a cigarette. It's not just the nicotine that's harmful. It's all this other stuff that's in there, the arsenic, the methane, methanol, carbon monoxide. And it's the burn at the end of the cigarette that makes it's so much more toxic. So when you say it's, nicotine replacement therapy is you're replacing one with the other, nicotine replacement therapy is straight nicotine. It doesn't have all this other toxic, all the other toxic chemicals in it.
And this slide, is from a very interesting study that I came across. Just to put things into perspective, when we think about people who are currently in older age, maybe not those in their kind of 60s range of older age, but those in their late 70s, 80s, 90s, and what was the culture, what was the environment when they were growing up? So now, I think public perception has largely shifted where in many places smoking is viewed as a bad thing. People tend to know that it's quite dangerous for your health. But many people who are now in older age grew up when, the doctor was smoking cigarettes when they came in for an appointment. So this was a fascinating study. It's a little bit older. It was done in the 1990s and published in 2001. And it was a nursing home in the States where smoking was actually allowed. So I'm not exactly sure how that was, but it was allowed in this nursing home. And they went in and asked the long-term care residents, what do you think, how bad is nicotine? What are their beliefs? What are their attitudes about smoking? And what they found is that most people did have kind of a general sense that it's not good, but overall it was grossly underestimated. So the figure on the left side of the slide is showing, how many people believe that smoking caused breathing problems. So 78% didn't realize it can cause breathing problems, but there's a good group that did not realize that. In terms of things like cancer, only 50% of the people actually believe that smoking is associated with cancer. 30% thought it has no effect on causing cancer. 20% just didn't know. And what they found was that when they asked people what are the harms associated with smoking, people would say things like, oh, it tickles your throat, it causes a cough. So they knew it's bad, but generally not a perception of the real risks that we know are there today. And in terms of unique aspects to assessing someone who's a smoker in older age, there are a few unique considerations. One is that the literature tells us that older people tend to be heavier smokers than their younger counterparts, and clinically we see that. So we see people who are smoking just amounts that are shocking. Saying they have 3 packs a day and they've done that for 40 years. They are likely to have higher degrees of nicotine dependence. So the kind of physiological, biological dependence on nicotine can be quite severe in older adults, both because of the heavier smoking, but also just by nature of having been smoking for decades and decades on end. They are more likely to have chronic diseases, both again related to age, but also the fact that they've been smokers for so long. And there's quitting smoking is challenging for everyone. But when you add the aspect of people having cognitive impairment, it can become even more tricky. Other things to consider are that there can be differences in the way nicotine is metabolized in an older adult. There are studies that show us that older adults are actually less likely to be counseled by healthcare providers to quit. So, the young person will go into the doctor's office and the doctor will tell them you should quit smoking. Maybe not as much in the older person. Although, when they do come in and do want to quit smoking, the literature does suggest that cessation rates are higher in older versus younger smokers who are motivated to quit. Another important piece to consider is motivations for quitting. So these might be different as someone reaches older age. It might not be as much about health. It might not be as much about saving money. It might not be as much about wanting to live longer. It might be something like wanting to set an example for younger generations, for other members of their family. It might be about identity and wanting to have, to live years of their life as a non-smoker rather than identifying as a smoker. So these are important things to consider when assessing these people.
So it's never too late. There are some studies looking into the barriers to smoking. Older adults found that they believe that at a certain point it's too late to quit, and that there's no real benefit to quitting. And oftentimes, as healthcare professionals, we think, well, that's their only remaining pleasure. But the notion of that this is, that it's too late to quit. There are benefits to quitting, and it applies to older adults as well. There's lots of literature showing the benefits of quitting, and the reduced risk of stroke is one. Lower respiratory tract disease in those with heart disease, if it reduces the risk of myocardial infarction, and certainly death, and it increases life expectancy, and it certainly improves psychological well-being. So why quit? So what we know that within 20 minutes of stopping smoking, the blood pressure, pulse, and the hand and feet temperature return to normal. Within 8 hours, the blood and carbon monoxide levels in the blood reduced by half. The oxygen levels return to normal. And within 24 hours, carbon monoxide will be eliminated from the body. The lungs will start to clear out mucus, and so people will start to cough a bit more. And then within 48 hours, the chances of having a heart attack start to go down, believe it or not. Within 48 hours, the nerve endings start to regrow, the ability to taste and smell improves, breathing becomes easier, bronchial tubes relax, energy levels increase, taste improves as well, circulation improves. And that's really important when you have somebody who may have circulatory problems and wounds, especially in a long-term care setting. So the circulation improves and healing of wounds can improve. Walking becomes easier, so coughing, wheezing, breathing problems will improve lung function. And within 1 year, risk of smoking-related heart attack is cut in half, so that's pretty significant. And after 10 years, risk of lung cancer is cut in half. So there's lots of benefits and good conversations to have with your patients.
And then another piece to consider when we think more specifically about the older adult is the link between smoking and dementia. So there is good literature out there that clearly supports a link between smoking and Alzheimer's disease as well as other types of dementia. Or there used to be some that believed that smoking was protective for dementia. And there were some theories about nicotine and its effect in the brain, and that nicotine somehow reduces risk of dementia. But over the years, that's been found to be clearly not true. And what's also been found is that a lot of these studies were funded by the tobacco industry. So I hear we're cutting out again. Can you hear us now? Okay, I'm going to continue. Let us know if you can't hear us. So what's been found is that much of the studies that showed a reduced risk of dementia in smokers were funded by the tobacco industry. So we know clearly that people who smoke are at increased risk of dementia. What's also been found is that smoking cessation can halt the decline in cognition. So people who continue to smoke, their cognition will continue to decline, whereas people who stop smoking, their cognition will not decline as much. So this graph might be hard to kind of piece together, but I'll try to explain it. It's a study where they looked at people in older age 68 plus. They compared smokers with people who've never smoked. And for the smokers, they offered some support to quit smoking. So what they tried to compare is the change in cognition, so whether cognition got worse or not, and they compared 3 groups. In green is the never smokers, so that's the line in the middle. And as you can see, as time went on, the line goes up. So that line is reflecting change in cognition. The cognition did a little bit get worse in the never smokers, and that's just people aging, right? They age and there are gradual declines in their cognition. The red line is people who were people who continued smoking, people who were unsuccessful quitters. So their cognition continued to get worse at an even sharper rate than the never smokers, and that's the effect of smoking. However, if you look at the blue line, which is the successful quitters, they came to match the never smokers in terms of their rate of cognitive decline. So their rate of cognitive decline slowed down and matched people who had never smoked. And then specific things to consider in terms of kind of process when assessing people who are older are things in terms of communication, so speaking clearly, speaking loudly. They may be hearing impaired, not using complex language, using shorter, briefer sentences. Keeping in mind cognition, and that someone who may be cognitively impaired may not be able to reliably provide a history. And I know some of the questions we ask in assessments of people for smoking around how many cigarettes a day and what age did you start smoking, and all these kind of details you might not be able to get that sort of information. Something very, very simple to kind of get a gestalt sense of someone's cognitive status is when you first meet them, ask them, oh, tell me when were you born, when's your birthday? And they might say, oh, April 4th, 1942. And then say, okay, so how old does that make you? So that gives you a quick, it's obviously not the most robust test of cognition, but gives you a quick kind of sense of if this person's cognitively impaired or not, and can be kind of easily fit into a regular interview as you're gathering your identifying information. Other important considerations, things like rules of family might be more than in people who are younger, and capacity issues. So people may actually not have capacity to make decisions around their own treatment. And then around specific questions to ask, this is not much different than things you would ask in a younger smoker. So how many cigarettes a day? How soon after waking up do you have your first cigarette? Do you smoke if you're so sick that you're in bed most of the day? And then really trying to understand what's happened if they've had previous quit attempts. And in older adults, they've had many, many years to have had quit attempts. And it'll often be helpful to find out what's worked, what hasn't worked, what's ended up happening, contributing to relapse. Okay.
I think the other thing you want to take into consideration when you're assessing is just even look around in the environment. If you're on a home visit and you see cigarette burns everywhere, that's certainly a huge, huge risk factor. So look at their clothes, look at their bedding, the chair that they sit in, and so on, and whether or not they've had any history of fires in their home.
Okay, so we'll move on to objective 2, which is treatment. Okay. So in terms of smoking cessation in general, which is obviously not the focus of this presentation, we're focusing on older adults, but we know that in general the literature supports a combined approach using medication and behavioral interventions. It is important to recognize that as people get older and as we may see cognitive impairment, it may be more challenging to do behavioral interventions, and it may be that they're less effective. We don't actually know. It's not been well studied in older populations. Important to know is that there are really no specific clinical trials or guidelines for smoking cessation in older adults. So when we talk about our suggestions today, this is really based on our experience and based on some evidence that's out there, but there really is no strong literature about this. Oh, okay. So although, as I said, we don't know that behavioral techniques can work as well in older adults, there certainly are important things to think about. In terms of motivational interviewing, that's something that's often used for smoking cessation and generally to help people with changing behavior. It is into that in details outside the scope of this presentation, but it is important to have some awareness of the basics. Other things to consider are, why are people smoking? Besides the physiological nicotine dependence, what purpose is the smoking serving? Is it addressing boredom? Is it addressing stress? Is it addressing just like wanting something to stimulate the hands, right? And being creative and figuring out how we can address those things. So whether it's engaging someone in relaxing activities, giving them something that stimulates the mouth, or stimulates the hands, like knitting or jigsaw puzzles. The picture of jelly beans is related to an experience I had a few years ago working in a long-term care home where they had many smokers and were really struggling with this. And they were very creative and came up with this jelly bean trick where they would keep a jar of jelly beans by the entrance, and then there was a particular patient, every time he was asked to go out to smoke, they would say, okay, but sit down and have some jelly beans. And he would sit down, have the jelly beans, and he would kind of forget that he had asked to smoke. So although, as a physician, maybe I would have preferred if it was carrots they were giving him, it did work very well for him.
And an interesting case that we had of someone who was transitioning to long-term care was a gentleman who would go to day program. His wife was really, really burnt out, and so she used to put a lot of candy in his pocket, so he would suck on the candies throughout the day. When he went to the long-term care home, there were a number of activities that they engaged him with, keeping his hands busy. He liked to color, but the other thing is, again, because that hand-to-mouth motion, they gave him lollipops, and the sugar actually helps with the craving. And he wasn't a heavy smoker, and nicotine replacement therapy really wasn't indicated because he was probably only smoking about 7 cigarettes a day. So his transition was pretty smooth, given that he was going into a locked unit, and the sugar really helped to mitigate some of the agitation and the cravings for nicotine. And because he had Alzheimer's as well, that was another factor. Is we're not worried about him gaining weight. In fact, it was important that he gained some weight getting into this new environment. So it worked very well. Okay, so the medications that we use for nicotine replacement therapy are the patch, the gum, lozenge, the inhaler, mouth spray, and then there's medications, bupropion or Zyban, and varenicline Champix. The first line is typically the overall benefits of nicotine replacement far outweigh the potential side effects. So there are some special considerations, though. You want to take into consideration if somebody's got dentures, the gum is not going to be a great thing. The whole idea when you're using nicotine replacement therapy, especially with the gum, you have to chew it a few times and then park it. or if it's the mint, you need to suck on it and then park it in your cheek. So that can be very challenging in cognitively impaired older adults. And we found that the inhaler is really good for cognitively impaired because they may not be able to chew or control how much they chew. It does have some side effects, though. It can cause some mouth irritation, GI upset, and if it's bothering them and they have cognitive impairment, they may not be able to express that. So, so you have to take into consideration all of these things when using nicotine replacement with older adults. So the mouth spray, the 1 milligram mouth spray, maximum of 4 sprays an hour. You would spray inside the cheek or under the tongue. And I really find that it's very helpful, and we're starting to use it so much more as a method of choice for cognitively impaired because it decreases the agitation and the behaviors related to smoking. It does maybe have a few little side effects, hiccups or like tingling lips. But generally, if you've got somebody who's in a long-term care setting, they have cognitive impairment, they're agitated, they want a cigarette, and they're getting antsy with the nurse, it's something that the nicotine mouth spray works very, very quickly, usually within 1 to 2 minutes. So it's really a good replacement therapy for older adults with cognitive impairment.
So in terms of the other pharmacological agents, so NRT, so what Marilyn was just talking about, things like the patch, the gum, the mouth spray, those are all nicotine, nicotine itself. There are other medications that can be used in smoking cessation, including bupropion and varenicline. And, we won't be talking about these in much detail today, but it is important in general when prescribing for an older adult to consider other things that we might not consider as much in someone younger. Things like what other medical conditions does this person have and how might a medication contribute to other medical conditions. Polypharmacy, so people in older age tend to be on many, many, many medications, which can become quite problematic. And we have to very much consider what other medications they're on, are there specific drug-drug interactions, and then changes in pharmacokinetics and dynamics. So these are changes as people get older in how the body handles drugs and how drugs affect the body. So these are all important, just general considerations, but it's not just the same as prescribing in someone who's 25 years old. In terms of the specific medications, bupropion or Zyban being the brand name, there's actually no literature looking at it in older adults specifically for smoking cessation. That being said, it is an antidepressant, and it has been studied for use in older adults for depression, and we do use it quite regularly in older adults for depression. But the studies, about Cessation, I can't, I don't know off the top of my head. So maybe we'll save that one for the end and see if others have some ideas, because I'm actually not very familiar with that. In terms of varenicline, so it has been studied in older age specifically to look at safety. So the studies in older age have shown that generally it is safe, but it has not been studied in older age to look at how well it works. Another piece to consider with varenicline is that some of it is cleared renally, so by the kidneys, and people can have declines in kidney function as they age. It's important to recognize that the studies where they showed it safe in older age specifically screened people to make sure they had good kidney function before they were included in the study.
So in terms of e-cigarettes, the one thing that we found with e-cigarettes was that families were trying to transition their older adult from cigarettes going into long-term care using e-cigarettes. Well, not all e-cigarettes were the same, and some of them had no nicotine in them. They were just cigarettes, the fake cigarettes that had a vapor coming out of them. But generally, cognitively impaired have difficulty using these products. They may not understand why they're given the e-cigarette. Some of them are not in the shape of the cigarette, so it's a little bit confusing. They're little boxes. You've got to press the button and inhale and so on. So it may be a challenge for them. The other is that if they've got one that kind of looks like a cigarette, they may, and this has happened a few times, they may get their hands on a lighter and light the device, and so that presents a challenge and a risk for fire, but also exploding batteries and so on. So it's really not a good choice for cognitively impaired. And the other thing is that you have to be able to fill the e-cigarette with the e-juice. You have to know what strength of e-juice to use. So again, for cognitively impaired, it's not a good choice.
Okay, so NRT can work. So I did want to highlight some findings from it. It was a small study, but I thought it was quite fascinating. It was out of Brazil, where they took all comers to a smoking cessation clinic. They had their own kind of system whereby they determined what treatment to give people. So they looked at things like what health insurance plan are they under, and what does their plan cover, how nicotine dependent are they, what does the patient prefer. So it was not randomized. And they put people on different agents for smoking cessation and compared outcomes between those younger than 60 and those 60 years and plus, and compared rates of successful smoking cessation on different treatments. Interestingly, for most things, they found that rates were roughly similar between older and younger adults. So like for varenicline, rates were roughly the same. For bupropion combined with NRT gum, rates were roughly the same. The only intervention for which they found a significant difference in rates of success was NRT alone. And for NRT alone, they found significantly higher rates of successful smoking cessation in older adults as compared with younger adults. So that's the row at the bottom that I've highlighted in red. So those younger than 60, 27% successfully quit smoking on NRT alone, whereas in those 60 years and older, 45.9% successfully quit smoking on NRT alone. So there was a very significant difference there. It's not entirely clear why that was, what they hypothesized in their study, but it had something to do with differences in nicotine metabolism in older age, but they really weren't too sure why that is. And again, it's a small study, so it's definitely, oh, sorry, there's an announcement overhead here. So it's not the be-all or end-all. But I think it does highlight that NRT can work, and we should consider it as a reasonable first-line agent to help our older adults quit smoking.
Okay, so we want to go back to Mr. C. And if you can unmute your microphones or type in the chat box, what would you suggest, having heard what we've discussed, what would you suggest for Mr. C?
I see people typing.
Yeah. So, elimination population, so consideration as well when prescribing.
Yeah, and I can speak more to that, which is, there's no clear guidelines, there's no clear answer. The question someone had asked was around, people who get older can have reduced kidney function and reduced liver function. So do we need to use the dosing for medications that we would use with kidney failure? I don't think, as a universal rule, we would have to do that. I think it's very, very case dependent. So we would certainly want to know what the patient's renal and liver functions are like before using these medications. And I think, in general, as is the adage in prescribing in older adults, start low and go slow. It applies when using these medications for smoking cessation, just as it applies to any other medications. So I hope that's helpful. Okay, I think we do have some answers.
So people are suggesting the spray, nicotine replacement, the patch, cysteine. Someone mentioned that cysteine is a plant-based product and it's cheaper than NRT, and it's effective as Champex. Yes, I've heard that in some of the presentations with Dr. Selby. Again, it's around, one of the concerns would be, again, how, if it's a natural product, how is is it going to affect the older adult in terms of its elimination in the kidneys? How are you going to dose them for, in terms of the geriatric dosing? So, and Helen, you're saying that cysteine challenges dosing is requiring. So, yeah, so that's something that's something that Dr. Selby could maybe answer if we have opportunities for questions by email. So let's just move on to the next slide. We're going to talk about the approach, and we'll at the end we'll tell you what we did with Mr. C.
Yes, so I did see there were many good ideas there around using NRT, using behavioral counseling, seeing what he might like to do, which I think, of course, that's a great thought, seeing what he might be interested in. I also think it is important to just not forget that he's a man with dementia, and we don't know, the case doesn't let us know exactly how cognitively impaired he is, but his degree around insight and his degree around his capacity to kind of make decisions around that might not be the same as it would be in someone younger. So it is important to keep that in mind. So in terms of a specific approach, this is not based on any guidelines. This is just kind of based on our collective experience, based on my experience with training in the nicotine dependence clinic, based on having familiarity with older adults, some ideas that we've put together. So the first thing is, without even thinking about the quit, thinking about acute nicotine withdrawal. So an older adult coming into hospital, an older adult moving into long-term care, those first days or two, as Marilyn really clearly described earlier on, there are acute, immediate, physical, very uncomfortable symptoms associated with nicotine withdrawal, and that can contribute to agitation and people just not being well. So whether or not someone's wanting to quit smoking, whether or not that's in the stars or not, it is important to address acute nicotine withdrawal if that's an issue. Behavioral interventions and creativity are critical and to be used throughout. So, I think we've spoken to that in terms of being creative with things like sugar, being creative with things like keeping the hands busy. And I'm putting that there to say, you can't just slap a nicotine patch on someone and think that, kind of hope for the best and think that they'll be okay. Even in using nicotine replacement therapy, there is a need for being creative in kind of how it's used, how it's presented to the person. And then most older adults will ultimately require medications given levels of dependence. So not all, right? There are cases, as Marilyn said, where people are not smoking very much, but certainly most older adults tend to be heavy smokers and have high degrees of nicotine dependence. So in terms of specific agents for pharmacotherapy, nicotine replacement study is the best studied medication in older age and potentially works better in older age than in younger age. that's one small study, but it is an interesting finding. We generally suggest starting with the patch. And in terms of what dose to start, it's not, we generally say 1 milligram of patch per number of cigarettes smoked per day. So if someone's smoking, 6 or 7 cigarettes a day, you might use the 7 milligram patch. If they're smoking, 15, 16, you might use the 14 milligram patch. You can also make, you don't just have to use 7, 14, 28. You can make creative, you can use 21 and add a 7, so it turns into 28, so you can be creative in how you combine the patch doses. So generally we do suggest kind of a patch as kind of a steady state, and then adding on a PRN, either the gum, the inhaler, the spray, the lozenge, something short-acting and quick to use as a PRN in those kind of acute, immediate cravings. So it's almost similar to how we might think of pain management, where someone might be on their long-acting opioid, dosed twice a day, but still has available breakthrough doses. So I like to think of it like that. They have their long-acting nicotine patch to kind of generally manage their overall withdrawal, but then in the peaks where they might have a craving, a PRN available. Okay, and then just quick, I think we're nearing the end, but important points to consider. Old age does not mean they need a lower dose. So I often see, people because they're 80, they only get 7 milligrams of the patch, and no one will give them more because they're old. That's not right. They may actually need more than their younger adult counterpart.
The other thing is that we had in long-term care, we had our groups were running, and some residents identified that they wanted to stop smoking, but the doctor really didn't believe that they would that using the patch was going to be sufficient. They felt that if they smoked, if they had the patch on and they smoked, they would end up having a stroke. so they elected not to offer it. But there's the new OMA guidelines certainly say that if people have a patch on and they have a cigarette, they're not going to stroke out, they're not going to have a heart attack. There were only a few people in the initial study using the patch that ended up having cardiac events, but people who are smoking heavily are at very high risk of cardiac events anyway. So it's always good to offer nicotine replacement therapy. The other thing is that if someone has high level of dependence, we have had someone who was smoking about 96 cigarettes a day. We don't know how she even had time to eat because she was smoking so much. But again, a couple of patches and then using the spray on top of that was really helpful.
All right, so Marilyn's already highlighted this point that you can use the patch even if someone's not actually saying they're ready to quit. It can still be used even if someone is going to continue smoking, and it might just generally help to reduce agitation, to reduce fluctuations in nicotine levels for, someone's going out and having a cigarette and coming in and going out and having a cigarette and their nicotine levels are going up and down. Having some available through the patch can help keep things more stable throughout the day. So I won't go into this in detail, but there are certain medications that and their levels in the blood can be affected by the presence of nicotine. So it is important if someone's quitting smoking to keep this in mind, that certain medications may need dose adjustments. So someone asked, is it okay to use an NRT patch and continue smoking? Yes, that's someone answered. Okay, good. So back to the case.
Okay. What happened with Mr. C? So the family were really leery about him using the patch because he had tried it while he was in hospital. He had some side effects and agitation, and he continued to ask to go out. They also gave him the e-cigarette, and they trialed it with the e-cigarette, but he lit it on fire. So that wasn't a good choice for him. So again, when he was agitated, what we did was we said, what we'll do is we'll use the spray. And when he asked to go out for a cigarette, because at least he knew and he remembered that he was to come to the nursing station and ask for a cigarette, ask for his lighter. And what he would traditionally get was 2 cigarettes because the nurses just didn't want to bother having to deal with him two times in a row. So they gave him 2 cigarettes. He would go smoke them both. And then come back in and have a fight with him about whether or not he's going to hand over the lighter. So what we did was we said to him, George, just hang on a second. I'm going to go get your cigarettes. I want you to sit down, and I'm going to give you some medicine, and then you can go out for your smoke. And so it's kind of a therapeutic lie for him. But his level of cognitive impairment really warranted because of so many risks that he'd actually push somebody over. So we gave him the spray, and he within minutes he was fine, and then he would get up and walk away. He didn't ask to go out. He just got up and walked away. Forgot that he asked for a cigarette. So the nicotine spray was very helpful. So those behaviors were really literally extinguished with the use of the nicotine spray. So we highly recommend that, and other homes are starting to use it very successfully. So we have another gentleman. He is a long-term smoker. He has a diagnosis of Alzheimer's. He's smoking about 20 cigarettes a day. Was smoking safely in his garage, and he was given 2 cigarettes in the package. The wife would say, here's your cigarettes. And she needed to go away for a family function, so they wanted to put him into respite while she's away. So they used the nicotine patch. They also put a cigarette patch in his pocket, cigarette pack in his pocket with no cigarettes in it. And so he had the nicotine patch on him, and he was just reminded that he'd already smoked, and so he didn't, there weren't any behaviors, and eventually they were able to taper it down. He ended up in long-term care, and he's able to taper down, and he stopped smoking completely. Again, with very little behaviors associated with it. The whole idea is making sure that somebody coming into long-term care, they're comfortable as they transition into long-term care, that you're not leaving them without some nicotine in their system, and you can gradually taper and eliminate it. And you know what, if when you pull back on the patch, the behaviors return. They start to ask to go out to smoke again, or they're asking for cigarettes. That's a signal that they still need the nicotine, and it's not going to cause any harm to them to have the patch back on. It's more harmful for them to smoke. So we've got some resources here for you. We're going to leave a few minutes for questions. So there's some resources for you. You can click on these, and there's other. The other thing is that for residents homes there is no plan in place, and it's just a little call out to those of you who run stop studies to try and make it a little bit more accessible for older adults that may have issues, cognitive impairment, or needing to transition into long-term care, to make it a little bit easier for them to get into your clinics and access the nicotine replacement therapy. The important thing is to make sure that the nicotine replacement therapy is on the MARS sheet. It's already prescribed before the person sets toe in the long-term care home, because if they have to wait for the doctor to see them, it may be 24 hours, it may be 48 hours, and then the behaviors are way off the Richter scale, and they may be sent back to hospital. So have a look at those resources. So now we've got a few minutes left for questions.
I think I can already see the discussion section very active about this question of smoking while on the nicotine patch. So there's been a lot of questions, a lot of answers. I actually don't have too much to add to the answers that are there. I agree with that. But, you know, smoking is dangerous, right? And the idea is that if someone is receiving a dose of the nicotine patch that is roughly equivalent or roughly less to the amount that they're smoking, it'll reduce their cravings. They may still, you know, have the behavior of wanting to go out and smoke a cigarette. But what we'll often see is that they'll go out, and instead of finishing the cigarette, they'll just have like a puff, maybe 2 puffs, and just find that they have this feeling of being full, almost like when you've just eaten too much and you just can't eat anymore. They're full and they can't finish their cigarette. That being said, absolutely it is important to monitor for signs of nicotine toxicity if someone's on the patch and they're continuing to smoke.
So I see how when you're talking about medical directives and the amount of nicotine allowed for a 2-pack a day smoker. There can be nicotine toxicity, indeed. I have seen it only once in long-term care where it affected the person and actually their speech. And when they pulled back on the nicotine, then the symptoms went away.
What is Gestalt? Ooh, it's one of those words I use but never think of how to explain it. It's like just a general sense, a general feeling of things. Maybe if I can do Sarah Coleman typing, maybe she'll have a better explanation than I do. But it's kind of a feeling based on the presentation.
Well, somebody's asking about the placebo, the sugar. Yeah, so I mean that's the one thing that Dr. Selby had. We had a session with the pharmacist at the long-term care home, the doctor, and the nurse, and so on. And again, the person that was coming in, he was, the wife reported that he was smoking 16 cigarettes a day, but the reality was is that he would walk away, he would forget that he'd smoked, so there were a lot of sort of cigarettes that had burned out on their own. So we figured that he was probably smoking less than 7 cigarettes a day. So what they did was they offered him lollipops, so he could go around and he'd have a lollipop in his mouth, and the sugar actually helped with the cravings. And the other is if he was a little bit agitated, having a glass of orange juice with a bit of sugar in it.
Someone's asking, will our slides be available? I think Stephanie can speak more to that, but I believe so. Can the slides be shared with with long-term care? So yeah. Stephanie will email them. In terms of in terms of permission to share, from my perspective and Marilyn's none, but I guess it would have to go through Teach. Whether there's any, if that's okay from their perspective.
The other thing is that you may want to have your PRCs, if you're from long-term care, the psychogeriatric resource consultants may have some modules that they can bring in and share with the staff. One of the things I find is that the staff in a long-term care facility, some of the staff may be smokers themselves, and they'll say, okay, well I'll take George out and have a cigarette, but then what happens on the day when you're not there? So it's really important to make sure that nicotine replacement therapy is offered and the individual is supported to have NRT.
Other questions, cases? We have about just 5 minutes left.
So someone says the institutional policy should be the staff should smoke with clients, but in rural communities, that's something that's again lack of knowledge and understanding of the use of nicotine replacement therapy. Again, the belief that nicotine replacement, if you have it and you smoke on it, you're going to have a heart attack and die. The other thing is that some of the staff will smoke with the resident because it saves the resident might take off. So they need to be supervised. I mean, then there are lots of smoking assessments and safety assessments for long-term care. I know in Ontario there are only 5 long-term care homes that actually have rooms that have ventilated smoking rooms. So if somebody has a cognitive impairment and they're a smoker, they need to be supervised or in an environment where they can't leave. But again, in the wintertime, that's not ideal conditions, is it? So it's important again to support using NRT.
Yeah, and I think what you're saying, you know, these are tricky issues, right? So a lot of it, you know, of course, in an ideal world, the staff wouldn't be smoking, the long-term care residents wouldn't be smoking, but that's not the case.
And again, with cognitively impaired, when they have the whole idea is that when they've got enough nicotine in their system, they're not going to be asking to go out. So you know, they're not seeking cigarettes. You know, even it doesn't trigger them. But if you've got a staff who's smoking and they smell the cigarette smoke and they're offered, then of course they're going to go out for a smoke. So again, having the spray on hand, or people who are not well enough to go out, using the inhaler. We actually had one gentleman that we used the inhaler with. He was cognitively intact, but he needed help to get in and out of bed. So at nighttime, when he wanted to have a smoke, he would yell at the nurses, and it would create this cascade effect on everybody in the room because he woke up 3 other cognitively impaired residents, and because he wanted to have a cigarette. So we put the inhaler beside his bed and said to have a couple of pulls on this. And that's what he did. He took a couple of puffs on the inhaler and then went back to sleep. So again, it's using creativity with products when you've got somebody living in a long-term care setting.
Other questions? I still see people typing.
Yeah, so people they're triggered by the smell on the staff. Yeah,
that's right. I mean, I think part of, you know, in an ideal world, that it would be nice if there were supports to help long-term care staff quit smoking as well.
Yeah.
Yeah. Okay. Yeah, we all agree. Secondhand smoke can be a huge trigger. Yeah. I agree.
Any other questions?
Okay. Still see people typing.
Third-hand smoke. Okay. Yeah. No, we have.
Hi, it's Stephanie on the line again. It looks like we haven't had very many other questions, so I might just do the wrap-up here, and if there are any additional questions, you can email Dr. Rostas or Marilyn with their contact information right here. And thank you so much, Dr. Marilyn and Dr. Rosas. That was a very informative webinar. And thank you to everyone who attended. The chat was very engaging. This webinar has been recorded, and I will be distributing the slides so you can share it with your colleagues, as well as the link to the webinar. So you can send this to the long-term care homes. And remember, a link to the evaluation and post-learning assessment will be distributed this afternoon, and you will have 1 week to complete it if you would like a letter of completion. And if you participated as a group, please email teach@kmh.ca with a list of names of those who attended by 2 p.m. today. And again, if you have missed today's presentation, you're interested in viewing it again, or you're interested in viewing previous webinars, a list of our archived webinars are found on our website, so you can view it there. Thank you, everyone, and happy holidays.
Happy holidays, everyone. Bye-bye. Thank you.